Hello and good evening to Midweek Matters. So this month is New Year, New Stronger You. And what we thought we would do is explore some of the main issues that a lot of our community have challenges with: pain, fatigue, and sleep. And this week we have the pleasure of being joined by Dr. Charlie Fairhurst and Susie Turner. Dr. Charlie Fairhurst is a paediatric consultant at the Evelina Children's Hospital in London, and he's been there for over 2 decades. He also sits on NHS England and has a wealth of knowledge regarding his work with cerebral palsy, not only in the paediatric world, but also as his clients have got older, as they enter adulthood and beyond. And Susie Turner is a specialist clinical physiotherapist at the Evelina. She also recently completed as a secondment at NICE, the National Institute of Clinical Excellence. She's finishing her master's and moving on to a PhD shortly, all of which have a focus on cerebral palsy. It is our great pleasure to welcome you both this week. Thank you very much for joining us.
Pleasure is all ours, isn't it, Super Suze? I'm going to share the screen, or give it a go at sharing the screen. Give us a sec. There we are. Which one do we want to do that? Why don't we do that one? Have you got that? Everyone got it?
Yeah, it's just not on. Yeah, there you go.
There you go. Off you go, Susie.
So thank you all so much for inviting us back. I think we joined you in one of your earlier sessions back in 2020, I think it was, or early 21, some point during the pandemic. So it's lovely to be back and start off 2024 catching up with you all. We're going to chat. We've put some slides together about pain in CP, and we don't have all the answers. And please, as Miriam already said, we're happy to try and answer questions, and we hope what we're talking about tonight will be useful, but I am sure there is lots that you can share with us as well, because we can learn from you too. So pain is very important. It's the core needs for everyone is, for us to be pain-free, and that's what everyone deserves. That's the point where everyone wants to be at, because pain, it's important to acknowledge, because it impacts onto all aspects of our life, our quality of lives, our day-to-day activities, and it makes it really difficult for us to focus on the day-to-day, let alone try and excel at anything if we are in any pain. So we just want to start off by acknowledging that. So pain and cerebral palsy, apologies for the minions, but we are pediatric after all. But how much of a problem is this, is what we want to focus on. How big is the problem? And often what people think is it's not really that big of a problem, but the reality we know is that it is a big problem. It is much bigger than people realize. So first of all, we just wanted to reflect on some of the research to tell us, what can we find out from the research? So there was a study in Sweden on just over 1,500 adults, and pain was reported in 2/3 of the adults with cerebral palsy. Now, a higher proportion of pain was self-reported, so that was from individuals who were able to report for themselves that they were in pain, as opposed to what they call proxy-reported pain. So this means that pain is likely underreported in those who aren't able to communicate as effectively or efficiently, and are relying on others to report for them. So that means that pain is potentially underreported in CP. More of the adults in this study were able to communicate independently, which is why they highlighted this. There was also no significant difference in relation to the level of cerebral palsy, the level of ability physical ability, functional ability, what they often refer to as the GMFCS or the MAPS score. And those adults with severe pain, it significantly impacted onto activity, work and sleep. Now I can see Tony has got his hand up. Do we want to, we can stop for questions throughout, or will you questions?
No, whatever works for everybody else from my perspective, Suze.
Sorry, I'm my mistake. I don't have any questions. Sorry, carry on.
No problem. So we'll move on to the next slide. And also this is a really relevant paper talking about that there are different types of pain. And this was a study carried out by Mark Peterson and his team in the US with 71 adults with CP. And through this study, we're able to describe different types of pain: musculoskeletal pain, centralized pain, neuropathic pain, and also, of course, we don't necessarily just experience one type of pain. Some of the individuals reported mixed types of pain, and types of pain is very variable in CP, and it is important that we recognize that it can occur through different mechanisms, and Charlie is going to talk a little bit more about that now.
So yeah, I mean, I'm a very boring doctor, and much of my training as a medical student, we had basically 2 years of going through neurology, and I work with lots and lots of brain doctors who try and confuse us all, but we are actually quite simple in how we function and how things go wrong. And really what we need to think about is, what's pain about? Pain is an input from something that's going wrong somewhere that then talks to the brain, that then gives you a sensation of ouch, quite frankly. And this can come in a variety of different ways. And what we see, particularly in cerebral palsy, is these 3 main areas, but predominantly what we call a mixed type. So the first is a sort of what we call a musculoskeletal pain. So that's to do with your muscles and your bones and your joints. And that's the pain receptors fire off because they get inflamed and or stimulated. And that comes from physical damage within your muscles, or if you've got muscles that can't work in a normal way, from overusing them or injuring them. And that's a very common way, as Susie showed from that Mark Patterson paper, a very common way of having pain if you've got muscles and joints and bones that don't necessarily work in the same way as the wider population. But what's very important to know, that's not the only source of where we can get pain from. So neuropathic pain, that's the next one that we're talking about, is pain that comes specifically from nerve damage. And sometimes that can be overwhelming. The musculoskeletal pain is very often a sort of a grumbling, gripey, crunchy kind of pain. The neuropathic pain is like someone stabbing you. And it's a really sharp, uncomfortable pain that you get from damage specifically to nerves within the nervous system. But you can also have a third form, which is the sort of pain that you get from your tummy, or if you're a lady, from your womb and womb lining as well. That centralized, what we call somatic or body type of pain. And very often that is an extremely complicated thing, because it's not just the nervous system saying there's pain and discomfort, but that has a huge emotional override as well. It sort of feeds into all the emotional areas of the brain as well. And so that not only do you get the sensation of pain, but that overwhelming emotion of pain as well. And again, as Susie pointed out from that paper, there's an awful lot, and from my perspective, actually the vast majority is that mixed type. So there's just a few slides here, and they're really just for you to help. They'll be online or whatever. I'm not going to go over these in tremendous detail, but these are examples, particularly the musculoskeletal pain, because I think that's a really important area, particularly as you are getting beyond pediatrics into adult care, which will go on later with regards to the sort of pains. But this is because your muscles are on the whole time. There's no rest. But also, it's not just from that overactivation or what doctors and physiotherapists call spasticity. You can also have that muscle type, that tonal type, where they're incredibly restless the whole time. You get the fluctuating movements, so that basically you're running the London Marathon 2 or 3 times every day. And that can lead to muscle cramps, and it can lead to muscle spasms, which also link in with the challenges that we have with fatiguing muscles. You know, if you're running the London Marathon 2 to 3 times a day, your muscles get knackered. And so the fatigue is a real problem when it comes to musculoskeletal pain. And we know that it's increased if you've got long-term problems with tightness, fixed tightness in your muscles, and you have changes within your joints associated with that. And also, as you get older, you get more of a problem with either arthritis in your joints or just a very low bone density, all of which can be very, very problem. But the other thing that we have to recognize as clinicians when we're coming to musculoskeletal pain is that very often some of the things that we do for you to try and help, to try and support you, to try and minimize that pain can actually be painful in their own right. So Susie and I do an awful lot of botulinum toxin injections to try and reduce the pain or to try and improve function, but they're not pleasant things in their own right. They're painful in their own ways. Surgical procedures are very painful in their own right. Therapy, if it's not targeted, if it's not focused, can be painful. Splint usage, orthotics can be painful. So we have to be aware of the challenges that we create as well as those that we're trying to support. Some of the sort of problems that you have with those sort of deep somatic pains, as I said, can be very central, but can be really difficult to manage. And part of that is because some of the pathways can get a bit jumbled centrally. So you have these 2 terms that I've got up there called hyperalgesia and allodynia. They look terrifying, but everything that we talk about in medicine is basically based on Latin. Hyper means increased, algesia mean pain. So that sometimes we find that sensation coming in that to you or me or to many people would just be a stroke or something like, can really be a painful thing. So it's increased pain that comes in. But there's another thing there that's important for doctors and neurologists we think of regularly, is this thing called allodynia, which again is a real confusion of nerve signals coming in. And allodynia means that something that is normally pleasurable can all of a sudden be really, really painful. And on the other side, something that to most of the population can be really, really painful can actually be a positive sensation. And that's just because we know that if the brain isn't put together in a quote unquote normal way, some of the pathways within the system can get a little bit jumbled. And so you can have a change in sensation and how you do it. Some of the examples of somatic pain that we have and that we see are things like chronic migraine, that sort of constant ache that you get all over your body, that we call fibromyalgia, that's very closely related to an awful lot of the problems that we're seeing in the wider population with long COVID in particular. So it's an area that we're beginning to look at really, really carefully again. But as I said, it's the bowel, it's your bladder, it's your deep sensory organs that again are examples. So that if you've got irritable bowel, or you've got constipation, or you've got cystitis and bladder problems, those are the sort of pains that we talk about with somatic. And we also know that pain causes problems, but problems also cause pain. So that we know that somatic conditions, in fact, all pain input leads to sleep problems. Now, the sleep problems can then cause problems with how we can manage our pain. We know that pain in its own right causes headaches, but yet headaches are painful themselves. And we'll go over a little bit more the sort of challenges of fatigue as well in some of the next slides. But what's really important for us to address, and for us to address from a sort of medical and clinical community, is how physical pain and emotional well-being and mental health are all really carefully tied together. And if you're in pain and you're in constant pain, that totally understandably leads to a high level of anxiety and depression, which again means that you can't cope with your pain as well. So when we're addressing pain, it's important for us not just to think of the physical things, but also the emotional and the mental elements as well. So I'm going to hand you back to Suze for the next few slides. Is that all right, Suze? I can't remember. Is this where I'm handing over? I don't know. You're on mute. You're on mute, Suze.
We can do it that way. But yeah, we have the nice guidelines in CP in under 25s. So that's children and young people up to the age of 25, and also cerebral palsy in adults. And these include guidance and recommendations on the common causes of pain, which includes some of the things Charlie's talked about in regards to kind of constipation, reflux, and we're going to go on to talk about some of these, and also, you know, highlights some of the complications and associated conditions, and the comorbidities, as we call them, that you may experience as well. And this can be a useful tool for yourselves, and also to share with any healthcare professionals that you see in adult services who lack the knowledge and expertise that you might want them to have. And we completely acknowledge that sometimes that's what you can be faced with, is the lack of knowledge sometimes in CP, and that is can be frustrating and challenging. And this is a really useful document to help educate others as well. Moving on, and what is really important about understanding what's causing the pain is that treatments vary depending on the cause of pain, and that's why we need to understand what the underlying cause is. And we talk about a term that's often used is this holistic approach, which is like looking at someone as the whole person, and not focusing in on one body part and thinking, okay, it's this, but looking at the whole context. And as Charlie's talking about, the kind of emotional impacts as well. And only when we can understand and work out, and sometimes it's a process of elimination to try and work out what is causing discomfort, then we can explore more effective and appropriate pain management options, because one pain management option isn't necessarily going to work for all. So we're going to now focus on some of the causes of pain in CP.
Minions!
And this is a very overwhelming slide, but there are basically so many different causes of pain, from if you have a gastrostomy, to sleep challenges, to muscle weakness, to dental issues are a huge source of pain, to tummy problems, abdominal pain, reflux, constipation, headaches, seizures. Physiotherapy also can be a cause of pain. We know sometimes as therapists what we do is a cause of pain. So there are many causes. I'm going to pass back, I think, to Charlie for the next few slides, I think.
Hey, whatever, come back in when you want to, Suze. I can't remember where we're doing the changeovers now, but hey, we'll prattle on. We speak as one voice, which is so good. Hey. So obviously, you know, what you had from Mark Patterson's group there is very similar to what we found in our South Thames review of our population of adults, young adults in this perspective, when we last reviewed. So these were the population of individuals with cerebral palsy who were born in the mid-1990s, when we sort of reapproached and reappraised 5 or 6 years ago. And we found with regards to musculoskeletal pain that actually over 2/3, 77%, over 3/4 of our population of adults with cerebral palsy were in chronic pain and discomfort. And the big areas were basically the leg, and in particular the hip. And there was this big, there was a significant difference between individuals who could walk, in which case it was around about 1/3 of them had chronic hip pain, and those who were not walking on a regular basis, who had over 50% of them had pain and discomfort in their hip. But there were other big areas such as back pain, particularly chronic lower back pain, which is really debilitating for an individual and is caused by all those musculoskeletal issues that we talked about to do with muscles, muscle weakness, muscle fatigue, but also tightness and just being out of alignment that can cause all sorts of problems. We found also 1/4 of the population that we looked at had shoulder and arm pain, and this was particularly strong in individuals who are dependent upon devices for their mobility. So we're using walkers and or we're using self-propelled wheelchairs, and this really isn't, you know, it's not rocket science. One would understand exactly why that is, but it's not something that the message has got through to the clinical community. So Susie, you're going to do the next couple of slides and I'll come back.
Yeah, just this x-ray is of a 22-year-old that we used to see who had a painful right hip, and we were able to manage his discomfort very well with Botox injections around the big muscles that pull around his hip, and that really would help for a period of like 3 to 4 months to help reduce discomfort. But we were able to refer him to adult orthopedic surgeon who felt that he was a good candidate for a hip replacement in the future. He's currently at university studying physics, and this is something I think once his hip becomes kind of more unmanageable for him, it's kind of the decisions with him as to the timing as to when. But sometimes surgery can be a good solution to help manage pain. Not always, but it can be. The next slide is of scoliosis. As we know, that curvature of the spine can cause a lot of issues with back discomfort, muscular discomfort, and again, some of the adults that we see benefit from Botox injections to help relieve some of that discomfort, and also underlines the importance of really supportive equipment and seating to help support if you do have challenges with curvature of your spine, because it can be really difficult in sustained postures as well. Moving on, yes. So early aging, which is also can be called post-impairment syndrome. So we know in cerebral palsy that you use more energy to do everyday tasks, and this energy use, along with the altered movement patterns and muscle and bone development, can cause what can be called premature early aging. And as we age as well, for all of us, there are changes to our muscles and bones, but this can happen earlier in CP, and you have a higher content of fat and connective tissue within the muscles, and this leads to weakness and wasting of the muscles, and importantly, what you will notice is muscle fatigue, and that chronic kind of muscle stiffness, early morning pain and spasms that may be familiar to you, maybe something that you experience, and also weaker bones, the thinning of the bones that can be talked about as osteopenia or osteoarthritis as well. So joint changes can become painful, reduced fitness, but also, as Charlie has said and highlighted, importantly, alongside the physical challenges, the emotional challenges of that as well, and how that feeds into it. And then that may lead to you doing less, being less active, and then it can become, you know, a cycle of difficulty then, because it keeps feeding into that. Next slide is, yeah, fatigue. So this is very real, and we would say almost universal in CP. And fatigue is not feeling a bit tired. It is much bigger than that. It is not feeling a bit too tired to do something, or somebody saying, oh, you know, you're being lazy because you're not doing X and Y. Fatigue is very real, and CP, the muscle weakness, the extra energy that you expend to do everyday activities, the changes in your muscles, the emotional aspects of that as well. It all feeds into that. If you have sleep difficulties, then you're going to feel, you know, you're not getting as much rest overnight. You're not waking up refreshed in the morning. That will feed into fatigue. You know, what you eat, your nutrition, all of that feeds in your mental well-being. This is very real, and we acknowledge that is a big issue for individuals with CP. So with sleep, although we're talking about pain, it's so important to reflect on, you know, how do I have real challenges getting to sleep, or do I get to sleep but then I wake up lots of times during the night. Maybe I have muscle spasms and cramps, which can be really disruptive to sleep. Maybe bladder issues, maybe needing to get up to go to the loo, you know, sleep hygiene, you know, you know, this is something for all of us to reflect on, how good are we about a good sleep routine, getting to sleep at a good time, not spending too much time on our screens before we go to sleep, and also our mood. All of these things can impact onto sleep, and that will impact as well onto our experience of pain and feed into that pain and fatigue that we're talking about, and that you may then have challenges with during the day. Daily activities, you know, just even getting moving for the day, transfers, dressing, these can all be uncomfortable. Stretches can also be a real source of pain, especially we often talk about, Evelina, with our young people that we see, that end of range stretches, when somebody stretches your muscle right at the end of range and holds it, can be very uncomfortable. And the evidence shows that that doesn't help to change the muscle length, and that can be a real source of pain. However, some stretches can help to relieve pain and muscle cramps as well. But having poorly fitting equipment, if your wheelchairs don't fit, any of your equipment isn't fitting, that can also be a source of discomfort. Splints and rigid footwear, especially if you have changes to your foot position, can be really uncomfortable as well. And sometimes therapists are really keen for you to use splints to improve how your walking might look, or to try and maintain your muscle length at your calf. at your ankle, even sitting in your wheelchair, but haven't stopped to reflect that actually maybe you don't want to use them and that's uncomfortable as well. So there's a balance, and we advocate very strongly that any piece of equipment or orthotic should be your decision as to whether you use that, and comfort is the most important aspect of that. I'm going to pass back to Charlie. This was his study that he was involved in.
Yeah, so we talked about that. So to a degree, that's giving us an idea about those musculoskeletal challenges and how many of the other factors of our daily well-being can feed into those. But also it's really important to recognize that the levels of pain and discomfort associated with other factors that we commonly see in young people, adults with cerebral palsy, are increased as well. And we found in our study that, again, over 50% of the female side of our population had chronic pain and discomfort in their tummy area, and a third of men. And the particular areas of association were heavy and painful periods, heavy, painful and irregular periods, constipation in particular. And it gets even worse if you are not up, you are not walking, you are not ambulant. And both of those problems become increasingly more marked with the more sedentary that you are. We also saw quite a bit of gastroesophageal reflux, but other areas of pain were significant and far more common than they are recorded in the wider adult population. So almost a third of our population of over 350 recorded chronic headaches, a 13% chronic chest pain. And other problems were very frequent, such as skin problems, pressure sores, and or nail challenges. So we're just going to go over a few of these areas for you, just to sort of, I'm not going to, they're here, the slides are here, I'm not going to go into great detail, but just be aware that your upper gastrointestinal tract can be really, really painful. If you're vomiting a lot, if you're regurgitating a lot, so if you've got gastroesophageal reflux and heartburn, they cause significant pain and discomfort in that somatic area. And sometimes the signs, if you're not easy to communicate, as Susie said very much earlier, right at the beginning, they can be hidden. So actually your clinician should be looking at problems associated with feeding going off, which again, we tend to find in many people with cerebral palsy. It becomes more of a challenge, more of a, actually, I don't really want, as you get older. And we need to look at that and address those issues. Is there anything clinically that we can do to help and support in those areas? And if your general practitioner is not getting on top of it, it is entirely appropriate that you go and see an adult gastroenterology service. And there are a wide variety of medicines that your doctor and or they in the gastro service can use that will reduce the amount of acid that you're producing, that will sit and sort of try and make it less fiery in your gut, that will make you less sicky as well. So there are a wide variety of medicines that we can use in the gastro area. But actually what we tend to see, and we see this is almost universal, Susie, isn't it, in our population, that constipation is such a problem. And the problem comes when you've got that lower gut pain and discomfort, that particularly if you're seeing an orthopedic surgeon, they'll put all the pain down to the hip or lower back, but actually constipation in its own right can be incredibly uncomfortable. And you need to think about what's going on with the amount of fluid you're getting in, the diet. And Susie and I always ask about poo, what the consistency is, how often you're doing it, what it looks like. And it's not just that we're very weird people. It actually, well, we are. is actually really important because it can give us a good gauge on what your gut health is. And some of the most simple things that I would recommend to you is we'll come on to this in the next slide, is just make sure that some of the medicines that you're on aren't causing this. Some of the easiest things that you can do is thinking about pre and probiotics, because they're really useful for your own gut health. So just the simple stuff like Yakult or Actimel, or the sort of stuff you can get from Holland and Barrett that can make those little bacteria in your gut be healthy. That will help you considerably with regards to management. But there are a wide variety of different laxatives that we use that work either like blotting paper, just to keep more fluid in your poop so it's easier, or they stimulate it so you can squeeze out your poop like you do from a sausage. But they're not without side effects, and including pain in their own right. So just keep a close eye on things. Your doctor should be keeping a very close eye on if you start a medication and something changes. It's likely to be because you've started that medicine. But there are a variety of other medicines that we can use for trapped wind and muscle spasms in your gut as well, such as Buscopan and Mebeverin. They're jumping all over the place, these slides. Anyway, there we go. But what's really important, as we talked about earlier, is just having an awareness that physical pain is so closely interrelated, not just because it makes us all feel rubbish, but actually, as far as the neurology is concerned, the areas to do with our mental well-being are really closely related to the areas of the brain that are to do with our movement. And so if you've got challenges in your movement, you are much more likely to have slightly more difficulties in controlling emotion and having anxiety. And that's nothing to do with you per se, it's everything to do with the neurology. So that we know that in CP, yes, there is an increased amount of depression and anxiety in the wider population. But it's hardly surprising. There is an increased amount of challenged behavior, and there is an increased amount of other neuro challenges, of neurodiversity, of autism spectrum disorder and attention deficit as well. And they're real, and we have to acknowledge them. And your clinical team should be acknowledging them and should be helping you and supporting with them if it's part of your general jigsaw. We all need to recognize our own emotional and behavioral challenges and have an awareness that they're common, and that actually they should be managed just as much as any physical problems. But again, as we said a few slides earlier, it's also important to recognize the effect that pain has on our mental health and well-being, and how we manage that will help us with our pain and discomfort. One specific area that I thought, not only, and again, Susie, I'm sorry about this, but when I was a very junior doctor, many moons ago, I spent a whole year doing obstetrics and gynecology, which is women's health issues. And actually, it's been really helpful to me as I've got older, and I've thought holistically about supporting the young adults and adolescents that I look after. Because gynecological issues or women's health issues are really common. They're really common in the population as a whole. And what doctors tend to ignore is that if you've got a challenge, it doesn't stop you having another challenge anyway. But actually what we also know, and what's really important for healthcare workers to recognize, is that women with cerebral palsy have more and not less gynecological issues. So the sort of challenges of premenstrual pain, mid-cycle pain in the menstrual cycle are really real and are really far more common. And the irregularity and the heavy periods are much, much more common, and are particularly, as we pointed out in our SHAPE study, associated with reduced mobility. So if you're in a wheelchair for most of your day, you are much more likely to have irregular, heavy and painful periods. And it's really important for your doctor and your wider health clinical team to not only screen for all gynecological issues that they do in the wider population, but also have a recognition that they should probably be screening for these issues more frequently rather than less frequently for and to help individuals with cerebral palsy. Some of the easiest things that we can do once you've assessed properly in terms of management is to reduce the amount of pain and discomfort that you have from the womb as the lining's coming away. And there are medicines that are widely used, such as mefenamic acid or Ponstan, that can be given just at that point of the cycle that could be very, very helpful. But we have many young people that we look after and through adult life that actually require hormonal manipulation of their periods to reduce the profound pain and discomfort and cramping discomfort that is present with gynecological issues. And at the end of all that, you have the problems associated with menopause, which is hugely challenging for anybody. And I put my hand up as a bloke. It is a real difficulty and something that is globally undermanaged in health services right across the world. But menopause, again, is much more challenging for women with cerebral palsy, not just because of those physical issues we've touched on, not just because of what Susie was talking about with the premature aging that's coming in around the 40s period to a much greater extent, and that post-impairment syndrome. But also at that point, you tend to have a reduction in your functional capacity very often, and the emotional issues that you have associated with that point in time. So there's a whole host of factors, not just your hormonal factors, that are leading into the challenges that you have associated with the menopause. And I know that you had a talk I saw from a gynae team back in November, and I would hope that they might have helped discussion with regards to that. But it's really important again to push for the normal national screening program for in particular cervical challenges and difficulties that should be being addressed in the CP population as well. And as I stated in the previous slide, it is really important that healthcare workers recognise that women with cerebral palsy have more and not less gynecological issues, and they should not be being ignored. They should be being looked at more carefully rather than less carefully. I'll get off my high horse. One thing that, again, we have to recognise within the health services is, as I stated earlier, some things that we do to help and support can actually lead to problems. And this is particularly important with the medication that we use and utilise to try and help with movements or bowel or bladder or whatever, because any medicine that you have has a yin and a yang. It can help, but also it can cause problems. And again, it's vital that you have a regular review of the medication that you're on, if you've got cerebral palsy and you're on lots of medication, because they will all be interacting. And actually, they may be totally inappropriate, because these may have been medicines that you were started on before the age of 18, and your general practitioner hasn't got a Scooby-Doo what to do after that, and you'll just be on exactly the same medicines when you're 36 or 54 as you were when you're 18, and you probably don't need 2/3 of them, and they're probably causing all sorts of problems and havoc, including pain and discomfort. And some of the sort of ones particularly are the movement modifying agents and gut pain. So medicines like gabapentin that we'll come on to in a little bit, but medicines like trihexyphenidyl as well, they can lead to problems with bowel and bladder in particular. Okay. Also, it's really important to have an awareness of the side effect profile of medicines as well. And actually, some of the medicines that we use for pain and discomfort that Susie will come on to now in the next few slides are actually really important for us to think about with regards to other challenges that we see with regards to things that have an increased frequency in individuals with CP. Over to you, Suze.
Okay, so we want to think over the next few slides, how can we help with pain? And there are many different things, from medications to psychology to surgery, sometimes to alternative therapies, and we're going to have a think about some of those now. So, you know, often paracetamol and ibuprofen are used for pain, but with a movement disorder, they're often not effective. And also then thinking, you know, the side effects that they're causing as well. And are we just adding in more medications? Muscle relaxants, I think we cover all these in the next few slides, don't we? So I think we will move on, I think, to the next slide. Yeah, so
the only other thing that I don't think we're covering is actually that challenge that we were talking about with low bone density, and actually that should be being monitored, particularly if you are not weight bearing, and particularly if you don't spend a lot of time being outside in the sunshine. And from my perspective, I think all of us, the wider population in the United Kingdom, should be on calcium and vitamin D anyway. But your doctor should be helping you screening, looking for low bone density, particularly if you're getting bone ache of no particular unknown region, and think about medications that are terribly easily and widely used, particularly in the post-menopausal female population that we know an awful lot about, that can improve bone density and reduce that pain and discomfort. Back to you, Suze.
Thanks. So yeah, commonly used muscle relaxants. So you may have been on or on baclofen, and that can help if spasticity is causing pain or muscle discomfort. You may get muscle cramps, particularly at nighttime. Sometimes we talk of what is termed like hangover pain. So if you've been, say, you know, sitting in your wheelchair all day, and then when you get out and stretch out in bed, then you can get muscle aches and cramps. And baclofen, particularly if it's used at nighttime, can help with that. In particular, it can also help if kind of muscle aches and stiffness first thing in the morning when you're getting out of bed. Sometimes that nighttime dose of baclofen can help with that. You need to be using that long term, and sometimes you may need to build up on the dose, but there can obviously be side effects. It can make you a bit sleepy if you take it during the day, and it can lead to increased constipation as well. So it's important to be aware of. Diazepam can be very useful to break that cycle of pain if you find you're in that cycle where it's worsening pain of spasticity and stiffness that is then feeding into pain, which makes your spasticity worse, and it's just going round in circles, and you need to break that cycle. So diazepam can be used if you need to help relieve that, especially if the pain's becoming more acute. That can be helpful. Clonidine also is a medication that can help to relax muscles, and you take that either orally or a patch, although we want to acknowledge that it can be much more challenging to be prescribed clonidine in adult services than in pediatrics, as to why confuses us at times why it becomes so much more challenging, but that's just how it is, unfortunately, at the moment, but that can be a useful medication, and some of these medications can be useful to help clonidine, baclofen at night time as well, to help with sleep, if your muscle pain is really impacting onto sleep. And botulinum toxin injections, as we talked about, as muscle relaxants, we commonly use those to try and help relieve pain as well as aiding function as well. So the neuropathic pain relieving agents that you may come across are gabapentin and pregabalin, which are used to treat the more neuropathic pain, but they come with lots of side effects, which I'm sure Charlie's going to want to say something about. But
no, I mean, these are, you know, these are controlled drugs. You know, particularly gabapentin is a controlled drug. It's a whole different family of medicines that is really difficult for doctors to prescribe. It's the same sort of challenge as we have with opioid medicine, so morphine. So it's not without significant side effects, and I'm always very cautious about their use. And from neuropathic pain, from my viewpoint, one of the ones that I tend to use, but then I'm a pediatrician much more so, is a medicine called amitriptyline, which has been around the block for a very, very long period of time and can be very useful for nighttime use at taking away pain and reducing anxiety. And in very high doses is used as an antidepressant, but actually is very good for pain relief and very good for just reducing and knocking back that horrible gnawing, particularly nighttime anxiety that many people unfortunately have. So
exercise can also be really helpful to reduce pain, and exercise has been shown it can help us to sleep better, and it can actually help with fatigue, because if we exercise, we will hopefully get more restful sleep. It can help to improve our mood, which can also have a positive effect on pain, as well as other benefits from kind of strengthening of muscles. It can help us in a functional way with day-to-day activities, as well as with social interaction and confidence. But also exercise can help to improve our bone health and reduce that risk of osteoporosis, which we know we're at higher risk of as we age. And there are other benefits as well, through improving our fitness, reducing risk of heart disease, and helping us to maintain a healthy weight. So it's not to be forgotten that exercise in whichever way we can do, and there's lots of good suggestions on, I think on the Up Movement website as well, about how to access exercise. And I know you guys have run lots of different activities and things as well to promote that. So important to remember. Other treatments as well, alternative therapies, cognitive behavioral therapies, sleep interventions can be helpful as well as acupuncture, osteopathy, homeopathy, massage. All of these things can also help. I'm not talking specifically about therapy, although physiotherapy, occupational therapy, can help as well. But I think we want to acknowledge it's also very challenging to access therapy, and more we're having to look to ourselves, aren't we, to try and self-manage. Some of the adults that we see use cannabinoids as well, like cannabinoid oils that they will access. It's a bit of a lottery as to what you get, and we would normally say Holland and Barrett, trying to go somewhere there, and it's I think it's very unclear how much benefit. I think it'd be very individual, the benefits you can gain. Charlie and I were involved in a research study. It was quite a while ago now, looking at a cannabinoid spray, oral spray, to see if that would help reduce spasticity and therefore help reduce pain, improve sleep. And unfortunately, we weren't able to show that it offered a significant benefit. It doesn't mean that it doesn't, it just means in that study we weren't able to show that it was a medication that was used in multiple sclerosis for adults. But we know some of our adults that we see, we're not advocating that you knock back a whiskey.
You got a choice, yeah.
But some of our adult patients say, you know, especially with dystonia, that alcohol sometimes can be the one thing that helps to give them a bit of relief and help them, as well as exploring, you know, mindfulness, psychology, and mental health and emotional support. There are lots of different things to access. I'll let Charlie finish.
So what do we need to do? What do we need to do? We need to, you know, again, part and parcel of the wonder of what you within the UP team, what we've managed to get the government to start to look at is actually how we help and support. You know, pain is just, again, going right back to the first slide that Susie talked about. It is the core need for all of us. We can't do anything if we're in pain and discomfort. We can't do anything if we're emotionally distressed as well. So what we need to factor on is that actually this is the core of all our rights and all our clinical needs. And what we need to do as a population from a clinical perspective, and also from you as the population with cerebral palsy, is ensure that your rights are there in place and that actually screening is taking place, and that you have someone, and we're trying to develop adult services within NHS England to look at how we can support you better. Because we need to think about what we do for you as in the wider population, but also what we do for you with cerebral palsy to support you as an individual and support you as a community. And one thing that Susie and I are developing, which is very much in line, and actually Miriam and Emma are helping us with, is to try and create an online resource that will help you manage your clinical condition. That's not overwhelmingly complicated, that doesn't just confabulate, that doesn't take hours and hours to fill out, but just allows you to highlight to your clinical services where your challenges are. And if they're getting worse rather than stable or hopefully getting better, that sends out a red flag. And then you have somebody who can be involved and help you through the processes and pathways within your own area and your own region to get the help and support that you need. So it's early stages from our perspective, and something that Susie is massively centrally involved with from a national conversation, but actually something that we're trying to drive, because we know, unfortunately, within the health services, resources are pants. You know, we are in a very limited financial world. So we need to be more clever. We need to be more intelligent. We need to help you, help yourself, and help the clinical community so that we can get the best resources and best support that we can do. It is very important that we as a clinical community and you as a community take the challenges seriously. And again, Susie was alluding, and we've had carers and support workers going on, oh, they're just a bit off today, or actually the fatigue, oh, they're just being, no, take it seriously. It's a serious problem. Take the challenges, take the changes seriously. It's a sign. You should be going to your GP and talking about things, talking about those aspects just as much as if you were short of breath or you were getting pain in your heart. Okay, it is as important. So all the changes, all the challenges that we've talked about over the last half an hour or so, take them seriously. Don't ignore them. Manage them. Easy things, as Susie alluded to, think about your diet. Think about your wellness. There is so much online capacity in terms of wellness and support and emotional support that is far, far better than there was before we were in an internet age. But the key to this is going to have someone that can coordinate and help you with your pathways of care as well. And as I said, and just to leave it on, it is an area that we're desperately trying to develop. There is some recognition within NHS England now that they haven't got this right, and that actually the training, the education elements of clinicians is really important with regards to the challenges that you have as an adult population with cerebral palsy. And I hope, you know, I am very, very old and very, very closely approximating turning into somebody who's going to sit by a fire and fall asleep all day. But as I've always said to Susie, I am happy to do that as long as we can look at each other and say, actually, something that we've left in a better state than it was beforehand. And that coordination of care and help and support for you as a population is critical to what we're trying to do. And I'll shut up now and leave you with a last minion. Yay! and I'll stop sharing, and it's up to you.
Thank you so much for that. It was really, really brilliant. I didn't doubt it for a minute. You've talked about lots of the reasons for pain, and I think there's a few questions. So are you happy to take some questions now? Yeah. Okay. So I know that Tony was saying that he had a question. I'll try and find you, Tony. There we go. Let me add you to the screen.
I have a question that I prefer to take offline and let other people ask questions. I will email Charlie since Thomas's my question.
Okay, thanks, Tony.
Are you Charlie or Charles?
I'm Charlie. I'm Charles. If I'm in trouble with there's only 3 people that call me Charles. That's my mum, who, God bless her, is no longer with us. That's my wife when I've done problems at home, and that's the gorgeous Susie, who I take notice of more than anybody else at work.
So you're Charlie of Fairhurst.
Yeah.
Okay, thank you.
Thank you, Tony. So let's remove that. Miriam, is there somebody else in the chat that I
think Yewanda had a question.
Yewanda, yeah.
Let's add a spotlight. There we go.
Yeah, hello. Yeah, it's a question for both. It's kind of a comment really, but it's just to express my ongoing frustration at adult services, because yesterday I had a meeting with a consultant who is, you know, supposedly looking after my CP, and it's rehabilitation medicine, that's the area. And as someone who has loads of different chronic pains, which are musculoskeletal and also neuropathic, and is non-weight bearing, wheelchair using, what I always hear is, do the exercises at home, do the exercises at home. And the thing is, when you have all this going on and contractures and so many different things, it's like when they say to you, do it at home, it's like you don't even know what you're stretching, that could be wrong, like there is no guidance, and it's just that there is nowhere to go for that kind of more hands-on approach to physio. And the physio sessions just seem to be about when you already have the pain or the problem or the contracture. There is nothing regarding prevention. You know, it just seems to be about cure. But sorry, that's not really a question, it was just a comment. And
one day it's core and critical to everything. I'll hand it on to Susie because she's the national expert, but that is absolutely the core of everything. to a degree, and to try and get that holistic support for you with somebody who understands and can help you realistically, rather than saying, oh, go away and try this, because it's not that easy. It really isn't. And we understand that, but actually to get that into an adult community where they only normally see people for a quick wham bam, acute problem, off you go, the long-term challenge is a real difficulty. Anyway, I'll shut up and let Susie.
Yeah, but you put it so well, Andy, because the big issue we have in accessing therapy services as adults is they will only see you once a problem has happened, won't they? Nobody is screening, as you say, to work out, when something is changing in anticipation of something that might become a problem. And that is what we are fighting very hard in the background to try and change. And it's what Miriam and Emma are working so hard to try and change. We want to change that moving forwards. In CP, so much focus has been on children with CP and not adults. But that is changing. The language is changing internationally as well. It's being recognized, cerebral palsy is not a childhood condition. It's a child onset, but it's lifelong. And we are pushing hard to work on lifelong care, lifelong surveillance, like screening. And it's going to take time, but please be assured that that is, what we are all pushing for. And certainly what my research is hoping to focus on is it's for adults with CP, even though I'm pediatrics, it's actually adults with CP that Charlie and I know that's where we need to be focusing on.
And Joanna, just a little plug, or not a plug, a push, or just to let everybody else know that on the website, on the UP website, is a self-assessment form. We know that annual reviews are not happening regularly for the 4s and 5s, like the NICE guidelines suggest, or for anybody else where we think there should be this surveillance. So there is an annual review that you can almost do for yourself, so that you can start to see for yourself if things are changing, if there are areas of greater need. And we hope that you'd be able to take that to your GPs and consultants and have a conversation.
It's, from a clinician viewpoint, having looked at it and reflected on it, it's really good. And is very clear and is very simple, and is very confluent with much of the area that we're sort of developing in a simple traffic light app to try and help you and help communication with your clinical services more clearly.
Thank you so much. And just it's so great to see you, Charlie, again. I don't know if you remember me, but
oh yeah,
I always remember how
Lovely.
awesome you are. Thank you. Thank you.
Fabulous, thank you very much. I'm just going to go with the order that I see the hands on the screen, so I apologise if I get the wrong order. Sometimes I get told off. But Sarah, you're next on my screen. I'm going to just
I have two things. First thing, I've been having gabapentin recently, and it's been the side effects I've had are horrendous. I've had like black thoughts, suicidal thoughts, and when I checked my the symptoms, like side effects, that can happen. So I'm weaning myself off them, but I do spasm more in the morning. I cannot exercise one bit on my own or anything. I'm on that THC Samloy. Is it that spray that's in your mouth? What is it? The Samlex.
Yeah.
Yes, I'm having them and dantrolene and loads of baclofen. Yeah. And so that's the first question. Yolanda, I've had the same problem, with physiotherapy. Once you get to 19 or over, I got an actual response saying, you're too old now and it's not like you're going to get any better.
Yeah.
So it's like you'd rather live when in desperate, but not prevention. You know, whether it's, you know, if you tick too many boxes, that can go against you. But it's like a precondition. It's never going to get any better.
Sarah, I'm just going to ask. I don't want to get this. Is not a you know, we're no, you're not. There isn't a community clinical appointment going on here. But who is helping you? Is that your general practitioner? Do you have a specialist pain team involved in your care? Because I think it's probably
No, I'm going to see a neurophysio.
Okay, but in
next
terms
week,
of doctors
but nothing.
that's managing with gabapentin, because as I said, from my perspective, and Susie is aware of this, I do see a lot of side effects, and those behavioural ones are not uncommon, and so I'm really glad to hear that you're coming off. I tend to find that too many of my friends are on too many medicines, and I very, very rarely find any of my friends who are on too few. But I think you need somebody to seriously sit down and look at what medicines you're on, how they interact with each other, how they might be causing your pain as much as they are helping your pain, and address those other issues that we've talked about today, because I think it's really complicated. I tend to find that doctors tend to just add another medicine, send you away for 3 months and hope that it'll go away. And then they'll see you in 3 months' time and add another medicine and send you off for 3 months and hope it'll go away. And on the whole, you end up on far too many medicines.
Yeah, and that's what they're doing. It's like instead of finding out the problem, here have some more Baclofen, or here have some more this. But I am seeing a pharmacist and the doctors, and we're trying to get.
That's good. That is very reassuring. And that
but now I know what it is, and I'm on sertraline as well, antidepressants.
They all interact with each other. They all interact with each other, and I think if you've got a good pharmacist involved, I think that's really important, because I think they're probably interacting to make your situation more challenging for you rather than less, Sarah.
Yeah.
There we go. Sarah, you can tell us what happens when you talk to the pharmacist next, because you keep us up to date. Thank you. Mandy, you're next on my screen, and I'm just whittling through because I know we're...
Yeah, I was just listening to you guys, and I'm in Scotland, and I don't see anybody at all for my CP at all. And anytime I go, I'm not guilty of going to the GP, by the way. I don't like to go, but I'll just say I've been on Baclofen since I was 14 years old. I'm now 47, and it's only about 20 milligrams, which is fair enough. But when you were mentioning I get really bad irritable bowel syndrome and things, and I never thought for 1 minute that it was related to the CP. But last year I'd done it over a bit. But last year I had terrible leg pain, knee pain. I went to the GP. I couldn't get to the bottom of it. He x-rayed it and all of this, and he just put it down to my CP. He said, "Mandy, I'll be honest, I don't know. Put it down to the CP." So I was like, "Well, can I get physio or whatever?" He's like, no, it's a long waiting list. I said, "What am I going to do for my pain?" And he told me to take paracetamol. So I'm also on one of the medicines that was on your list, Clonidine, that he gave me for menopause. So I went in early menopause according to him. But I can't get HRT. He doesn't want to give it to me because of my CP, but he doesn't know enough about it. So my question, I know I'm jumping about, my question is, how do I get someone to look at my CP, get referred to like a doctor like yourself that knows about it, to maybe look at all these things So I've got the whole gambit of what you were talking about, fatigue, pain, all these things that I just put up with, and nobody doesn't help me. So how do I get referred to somebody to just look at the CP, say it's your CP or it's something else?
Can I ask, Mandy, whereabouts in Scotland you are?
I'm in North Lanarkshire, near Glasgow.
Yeah.
I referred myself to online, I referred myself to CP Scotland.
Yeah.
I found them and they gave me a wee bit of physio and they were a bit helpful, and they went and got my wheelchair changed so that I'm sitting up better and things like that to help my pain. And they thought that just to take paracetamol was a ridiculous response. But I just wondered if I could go to a specialist to look at my CP, look at my body, and just see what we can tweak and see what's going on.
And there is a consultant in Glasgow who I'm trying to remember her details.
Miriam, and do you know her very well, don't you?
Yeah, we can pass on those details. The other thing that I would say that we're being encouraged to do, and I'm not sure what Charlie feels about this, is looking for your community neuro team, asking your GP to refer, and ask the community neuro teams if they'll see people with CP, because they might give you a more holistic overview. The other thing you can ask your GP about is any rehab consultants, but we can talk offline and I'll show you what we've got, Mandy. And
though again, sometimes, unfortunately, as we stated, and as Joanna has found, is that sometimes some of the rehabilitation, adult rehabilitation, they're focused very much on an acute problem like an acute stroke or acute challenges of neurological disorders, and actually chronic problems. They have much less of a holistic overview. But we are trying to encourage education of adult services, whether that's neurology or neurorehabilitation, in a more holistic way. We are developing it within NHS England, which unfortunately doesn't, but we're very confluent and in lots of discussions with what's going on in Scotland and Wales and Northern Ireland as well. So these are things that the conversation that have been very much involved with, and what Susie and I are trying to agitate internally. They are conversations that are what I would love to do in 6 or 7 years when I finally retire, is to be able to look back and say, actually, we've got these pathways, if they're not even complete, that they are there, that in every region of the United Kingdom, somebody's got somebody that they can be turned to. And it may well be that actually your primary first point of care and support to help you is a nurse practitioner or a specialist physiotherapist who can then help you work your way through the pathways of where you need to see, and to have a variety of clinicians within your own locality or region who are interested and knowledgeable about helping you and support. And if we can get that situation, I would be a very happy old man.
Yeah, I think there will be somebody, Mandy, within the Glasgow area who will have that knowledge to support you. It's a case of having to not fight for it, but to push for it, you know, and working out, you know, don't give up, because there will be somebody who can help you, definitely. So hopefully Emma and Miriam can give you a bit of a steer. CP Scotland would also be a good, or to go back to and ask who they would recommend as well.
And CP Scotland have just got some money to offer some annual reviews for adults with CP. So I don't know how long ago you saw them, but it might be worth contacting them. But give me an email, Mandy, and we can talk, or we can arrange a time to chat. Beth, are you okay for me to come to you now?
Yeah.
I have a knee injury and I'm waiting for an MRI and a general anaesthetic. There is a reluctance by the local hospital to do this. How can I make this happen, please?
I think I'm going to be there's something called a poacher turned gamekeeper. And that's when somebody on the inside wants to be helpful and supportive on people on the outside to beat the inside. I would say that you should go to your hospital complaints or hospital process. I can't, what's it called, Susie? There is
Pals.
Your PALS service, and ask them to look into it on your behalf. So there's no reason why you should not be, that they should not be doing that for you. And your patient advisory liaison service, or PALS, should be able to look into that for you. So I would go to them, and there will be a telephone number on their website that you can use your communication aid to communicate with them. And they will look into why these problems are there, and there will be a sort of review. And generally when people go to PALS, as a poacher turned gamekeeper, the management start taking an interest in what's going on, and I think you might find that you're much higher up on the waiting list.
And Beth is a brilliant advocate, so I'm sure that you'll I have no doubts that you will get that. I'm going to go to Will next. Is that okay, Will?
Yeah, that's fine. Thanks, Emma, and it's good to be back again. My question is a little bit of a different question. So sadly, recently I had an infected baclofen pump, which it had to be removed after a lot of battle this year. I've been in and out of hospital, so I've just gone back onto oral baclofen, but I'm finding that it's interesting. I know that baclofen was related to constipation, but I'm finding that my toilet habits are sort of changed. Is that normal to go from the baclofen pump into the spine back onto oral baclofen medication until it gets used to you again? So that's what my question was, really.
I think part of the main problem with baclofen is that our spines, our whole nervous system is basically wrapped in cling film. And for any medicine that's going to work on your spine level to help you relax, it's really difficult for it to get to where it needs to work. And so in order to get a few drops of effect, when you're taking oral baclofen, you have to take a bucket's worth of medicine. And if you take a bucket's worth of medicine, you have a bucket's worth of side effect. Whereas if you have an intrathecal baclofen pump, if you have 10 drops of intrathecal baclofen, you're going to get 10 drops of effect. But you need to take a full bucket to get 2 drops of effect if you're taking it enterally. From my perspective, and again, I'm not going to interfere with your clinical and clinician pathways, I think if you've had an infected intrathecal baclofen pump, that's one thing. If it's out and you're clear and everything else, that should not be stopping you and your clinical pathway team thinking about, okay, that happened, doesn't necessarily have to happen again, but are you in the place of thinking about having another intrathecal baclofen pump?
Yeah, the surgeon that I have now, because I went for a second opinion, wants to try it again into 6 to 12 months to see if we can do it again. So
I think that's entirely reasonable, Will, and that from my perspective would be the sensible option. Susie, would you agree?
Yeah, 100%. And then it's whilst you're on the oral baclofen as well, it's making sure they're aware of your change in toilet habits and managing that with the right medication, because that can be managed hopefully without further side effects. That's always the drawback, but that would be worth exploring for now.
Thank you. And Emma, I'm happy to get involved in because I work with support workers and PAs, so I'm happy to get involved in your work to sort of
Fabulous.
to understand. So just got me a line and I'll arrange it with you.
Okay, will do. Always happy to have everybody on board. And just lastly, I think it was Alexandra that had a question.
It's more like a comment because, like, I've always had my CP is very mild. So when I have my pains, my muscles get very tight, and then I asked my GP to if I could go on baclofen, but they said that I couldn't because it would leave me very, very weak. So now, like, I don't have anything to take. Like, as you say, paracetamol doesn't work.
So I think that, so again, as Susie alluded to earlier, Alexandra, I think, you know, it's difficult because your GP do, but I think you can say you talk to the specialist team from the St Thomas's Hospital. They won't know the Evelina St Thomas's Hospital, and we would potentially recommend that you try some baclofen at night time to help that at least. I mean, yes, you might get, but I don't care if you're weak overnight. You know, if you're meant to be fast asleep, you be as weak as you want to, girl. But actually, if it breaks that cycle for you, it can be a very useful thing.
And how long does the effect take? Because, like, will I still be weak in the morning, or?
It's so baclofen. So there are medicines are a funny old malarkey. If you've got epilepsy, you've got to be on a medicine to try and stop your epilepsy. Equally, if you've got diabetes or something like that, you've got to be on a medicine to try and get your sugars right. But if you've got a movement disorder, what you do is you start a medicine. If it's helpful, you carry on. If it's not helpful, you stop it. And or if you hit a side effect, you come back down on the dose.
Yeah.
And anyone, you know, a poorly trained monkey who's vaguely trained as a doctor should be able to manage that and help and support you.
Thank you, Alexandra.
Not being too rude about my clinical colleagues, but
I'm just going to ask Becky, because she's just put her hand up, and I know that we've just gone over time, so I apologise, but she's just put her hand up, so I don't want to let her go without her asking her last question. Becky, over to you.
I think I was talking about this last week in the community chat. I don't know whether you guys will have any ideas about this or whether you know whether this is a problem. I'm currently on a mixture of Ducosate and liquid senna for constipation, but currently liquid senna is not available. They've put me on tablet form senna. It doesn't seem to be working as well. I just wondered whether there was any sort of knowledge or background as to why that might be and what other options might work better.
it's a different medical. I mean, we're having real challenges across a whole variety, and I don't want to get too political or anything, but frankly, following Brexit, procurement of medication has been an absolute nightmare, and we are constantly running into problems with getting procurement of different formulations of medicines. And even if you are on the same medicine, if you have a different manufacturer of that medicine, you get different effect. You know, I live with it in my family in a variety of things, and if it just lurches from, you know, manufacturer from Belgium to one from Ireland to, you don't get the same effect. You know, it doesn't matter what people say, you just don't get the same effect. I have to be honest with you, I am not a big fan of senna anyway. I give another talk about the 10 layers of medical hell, about some of the 10 worst things that doctors can do for you. And senna and lactulose are both firmly on my list, not least because actually it's just given out. But senna is incredibly uncomfortable to take, and lactulose turns you into a beer factory. So from my perspective, I think the Docosate, you've got to look at what dose of you are on with regards to that. I think if they're not getting liquid senna, they should be considering something else like bisocodyl. from my perspective. I have many of my friends who, and I know if we were all living in France, we get all our medicines up our bottom, because that's just the way that you get it in France. And actually, don't be scared about suppositories, because actually they are really good and really useful when it comes to constipation and constipation difficulties, and probably way better than having senna. So my recommendation potentially would be a bicodal suppository. And I have lots of my friends that take a bicodal suppository every 3rd day, and that manages and maintains things very, very well.
Okay, thank you
so much. And thanks, Becky. That kind of brings us to the end of the evening. I know that we've slightly overrun, and I try not to, but I do apologise. But it's really
because I prattle on, Emma. Don't blame yourself. It's me.
No, it's
Susie has to put up with this on a daily basis.
But it's lovely to have you there, and it's really interesting from my perspective to hear, even down to the medicines that you can access or that the clinicians are knowledgeable about within adult services is different within paediatric services, which is a really interesting thing to think about. So that's what I'm going to go away and think about. I hope everybody's enjoyed the sessions. Thank you so much for coming.